let's talk about stroke protocol. That is what we do when we suspect a patient has come with stroke. So whenever we suspect a patient with a stroke, what we have to look to suspect a stroke, that is we can do that with the help of mnemonic fast. That is, we have to look at facial weakness, arm weakness, slurred speech and all, and we have to look for the time since when it started. And when we suspect stroke, the patient should be sent for NCCT head and the blood glucose should be taken. Why blood glucose? Because low blood glucose less than 60 milligram per dl can mimic stroke. Okay, why do we do NCCT head? NCCT head is mainly done to rule out hemorrhagic stroke, and MCA territory edema should not be more than one third of the MCA territory. Okay, now once there is no hemorrhagic stroke and there is no edema more than one third and blood glucose is more than 60 milligram per dl, what we have to do, if there is no contraindications to the TPA administration, and if BP is less than 185 by 110 mmHg and one set is less than 4.5 hours, then we have to go for recombinant tissue plasminogen activator, that is thrombolysis injection. So we give tenecteplase and alteplase. On giving this thrombolysis, there is 6% risk of bleeding. Okay, even after giving thrombolysis, we have to take the patient for CT angiography. Once CT angiography is done, look for any large vessel occlusion. What are the large vessel occlusions? Large vessels like basilar artery, MCA and ICA, internal carotid artery and middle cerebral artery and basilar artery. If any large vessel occlusion is present, go for mechanical thrombectomy. Okay. Now if the onset of symptoms is more than 4.5 hours but up to 6 hours, then also we have to first do NCCT to rule out a hemorrhage. Then we should not give thrombolysis. We should directly go for CT angiography in between 4.5 to 6 hours. If there is large vessel occlusion present, then go for mechanical thrombectomy. But if the time has crossed 6 hours, so between 6 hours to 24 hours, we have to again do NCCT to rule out hemorrhagic stroke. Then we have to do both CT angiography to look for large vessel occlusion and CT perfusion to look for the penumbra. If there is a large vessel occlusion and the mismatch score on CT perfusion is less than 6, that is there is presence of salvageable penumbra, then we should go for mechanical thrombectomy. Thank you guys, this is all about stroke protocol.